Many times we see physicians also, or we see many of our colleagues discussing these points, that whether routinely we should shift these patients from ARB or ARNI to ACE inhibitor or AC inhibitor to ARNI, or we have to wait whether the patient, when patients deteriorate, then only we should, or when patient is not tolerating AC inhibitor, then only we should shift it to ARNI. Now, few of the important points I would like to discuss here, like your typically whenever we say that a heart failure patient is a stable patient, actually these patients are not stable. You will be surprised to see few of the epidemiologic data which have come out in different randomized control trials. It has been found that the typical 20% of the stable heart failure patients usually have a sudden cardiac death in almost 60% cases. So that shows that those patients, heart failure patients who are apparently stable, are actually not stable. They have a they are at potential, potentially they are at a high risk of developing sudden cardiac death. And number one. Number two, not many of these patients will die because of pump failure. Many of these patients will die because of sudden cardiac death because of some ventricular arrhythmias or some other complications. So that shows that these patients, actually we should not wait till the patient deteriorates. We should give them the best molecule which is available in our clinical practice, and we should not deny these patients the benefit of ARNI compared to other molecules like AC inhibitor or ARB, because this molecule ARNI has clearly shown its superiority over AC inhibitor or ARNI, and so we should proceed with the clinical and scientific data which is available to us till now. So ARNI should be started as soon as possible in all patients of heart failure reduced ejection fraction, irrespective of whether they are a de novo heart failure patients or whether they were acute decompensated heart failure patients or a chronic heart failure patient. So I will be coming to this point also, what is the difference between a de novo heart failure and an acute decompensated heart failure patient. Now, heart failure management society has clearly mentioned that ARNI should be used as a first line therapy in heart failure reduced ejection fraction, whether patient is using AC inhibitor or not, in all patients of heart failure reduced ejection fraction, and it's a class 1A indication. De novo heart failure patients are those patients who actually are heart failure. They were not a known case of heart failure patients, but they suddenly present for the first time with heart failure, and after that only they were diagnosed to have some certain elements in their heart which can predispose them to heart failure. Like a patient who has come to emergency with acute breathlessness, and we have seen that patient has already developed LV dysfunction, and patient is having pulmonary edema, or patient is having ischemia due to coronary artery disease and presenting with heart failure. But patient was not aware that patient was having this disease. So they have presented first time as heart failure only. So these are de novo heart failure patients. And there is another one big group, that is the acute decompensation of chronic heart failure patients, like patient who is a known patient of CAD who had undergone angioplasty or CABG. These patients, because of some other complication, they may present with heart failure. So these are acute decompensation of a chronic heart failure patient. So these are actually potentially chronic heart failure patient because they had an existing CABG, post-angioplasty, LV dysfunction patient, anemia, CKD patients. Now suddenly they got decompensated and they presented to ER emergency with heart failure. So these are two different groups, completely different groups. So what is the difference between these two groups? Now if we see the data of these two different groups, it has been found that actually the acute decompensated heart failure patients actually are having a worse clinical outcome, number one. Number two, they have a worse, because they are chronic patient, they are already having severe LV dysfunction. So medication compliance is poor, and because of infection, diet or fluid overload, these patients can present with acute decompensation. Whereas de novo heart failure patients, there is no history of heart failure. These patients usually they come with some acute event like viral myocarditis. In post-COVID situation, we frequently find that viral myocarditis is a major cause of LV dysfunction even in young patients without any coronary artery disease. Then in some patients, coronary artery disease leading to acute MI and leading to LV dysfunction, and this patient is presenting to us with acute heart failure. So these are typical de novo heart failure patients. And these patients will have an acute hemodynamic deterioration in de novo patients because they are presenting only for the first time.